Can you share your screen? You have to unshare, yeah.
Yeah. Is the screen visible?
Yeah.
Yes, yes.
So thank you to the committee, particularly Dr. Chitra, for the invite to speak. And the topic assigned to me is Fuchs dystrophy with cataract. So in this scenario, we presume that as there is a cataract, and as surgeons, we don't do surgery in an eye with cataract without removing the cataract. So the only question remaining is whether to combine the cataract surgery with a corneal procedure or not. And I'll just try to simplify when and why we should do combined surgery. So when a patient with Fuchs dystrophy and cataract presents to me, these are the three questions that I feel we need to answer. And if we have satisfactory answers to these three questions, the decision making becomes very simple. And essentially, all medicine and all surgery is good decision making. So the first question is, does the patient need a transplant procedure at present, that is right now? Is a corneal transplant indicated? We are, of course, knowing that all these patients do have cataract coexistent with the Fuchs dystrophy. So some cases, the decision making is fairly simple. So if we have a patient with an eye which looks like this, in this case, I know that the lady has Fuchs because the other eye has less advanced Fuchs dystrophy. It's obvious that this eye needs a corneal transplant procedure, and therefore you need to combine a corneal procedure with a cataract surgery. You can't just do cataract surgery in such an eye. Other cases are less obvious. Nonetheless, we have plenty of clinical signs which help us decide that the cornea has lost its reserve of functional endothelial cells and therefore needs a transplant procedure. The most prominent signs being presence of stromal edema, epithelial bullae, and areas of irregularity and confluent guttae, which are very prominently visible in retroillumination. So this patient, again, with Fuchs dystrophy and cataract, it's a no-brainer that you need to replace the endothelium and you also need to do cataract surgery. Likewise, this patient of mine, who in addition to Fuchs dystrophy and cataract, also has microcornea and a cornea plana, we can see very clearly on retroillumination that there are profuse guttae, there is stromal edema, and therefore the cornea is already starting to decompensate. And you need not worry whether or not the patient needs a transplant. The patient definitely needs a transplant in addition to cataract surgery, as doing only cataract surgery in the presence of corneal edema is only going to worsen the corneal edema. So the first question to answer is, does the patient need a transplant procedure at present? The second, and this question is more pertinent and more difficult to answer, is the particular patient likely to need a transplant procedure in the near future? So these are the cases which do not have clinically obvious corneal edema, have Fuchs dystrophy, and have cataract. And these are the patients where decision making is a tad tricky. So let's say this patient, which the eye is showing a lot of guttae, the patient has Fuchs dystrophy, the patient has a cataract, but there's no clinically obvious edema. So is this patient likely to need a transplant in the near future? If the answer is yes, then of course we would like to combine the two procedures. If, however, the answer is no, then it would make sense to do the cataract surgery with adequate precautions and wait on the corneal procedure. So what are the tools that we have to answer this question? Dr. Ashish mentioned that corneal thickness or pachymetry and various cutoffs have been suggested by different studies. Some suggest 600 or some suggest 640 microns, beyond which you need to do a corneal transplant. I need to point out here that this is not absolute. Indian corneas are in general thinner than Caucasian corneas where these studies have been done. And we have patients with 450 microns or 500 microns or something in between as their usual corneal thickness. So this can be tricky, trying to just keep your central corneal thickness as a cutoff for surgery. Likewise, specular microscopy is useful, but just looking at the counts is not always very clear, because as Dr. Ashish pointed out, in Fuchs, you can have areas with relatively good endothelium and areas where it's not so good, and the reproducibility is poor.
1 minute left.
Okay, so Scheinflag tomography has certain features which can give us clues to these early cases. And there are these definite signs. If all of them are present, it's very, very likely that the patient will need a cataract surgery, and that's what the survival curve indicates. And those patients, you need to do a triple procedure. The third important question is, what are the likely outcomes if we combine the two procedures? So if this question was asked 2 or 3 decades ago, you would say that with a PK, cataract surgery, and intraocular lens placement, At 1 year, about 70% of patients would have 20/40 or better vision. Now, with selective replacement of endothelial tissue, that number goes up to as high as 97% with DSEC and as high as 100% in some cases with DMEC. So you have rapid recovery, excellent long-term survival of the graft, and excellent uncorrected as well as corrected visual acuity. So why would you go for twice the number of surgical procedures, the incumbent risks, anesthesia, and the costs to the patient? Right. So from the patient's perspective, I think a single surgery versus 2 surgeries makes a lot of sense. There's a high degree of predictability and likelihood of long-term graft success with excellent visual acuity. So with appropriate case selection, even in more advanced cases, you can have excellent outcomes with combined endothelial keratoplasty and cataract surgery. And this, I believe, delivers optimal results.
Thank you very much, Dr. Jayesh. That was a very succinct talk.